Very good evening, friends. Now you are watching Surgical Educator RKT. Today we are discussing about management of upper GI bleeding by angiography, and when we are working in such a setup where not sophisticated instrument or diagnostic modality is not available, and we are having nasogastric tube, popularly known as RISE tube. So through RISE tube we can diagnose and exclude upper GI endoscopy and upper GI bleeding and lower GI bleeding, because in previous video I have told you that bleeding proximal to ligaments of treats. If bleeding source proximal to ligament treats, it is called upper GI bleeding, or if bleeding source distal to ligaments of treats after duodenojejunal fracture, it is called lower GI bleeding. We also discussed sign and symptom, melena, definition of melena, hematemesis, hematochezia, rectorrhea, etc. Today is a short video. How can we diagnose roughly, not exactly, through RISE tube? If we put a RISE tube 50 centimeter and in 40 centimeter there is a gastroesophageal junction normally. If frank blood present, then aspiration, we analyze the aspirating fluid. If color of the fluid is a bright red or frank blood, that means there is a massive recent bleeding. इसका मतलब हुआ अभी हुआ है और प्रोफ्यूज मतलब ज्यादा मात्रा में ब्लीडिंग हुई है. Some of my subscriber asked me to give lecture in mixed Hindi and English. That's why I am trying to do that. If we put a nasogastric tube 50 centimeter, when we enter the stomach and aspiration fluid is bright red, that means there is a 100% upper GI bleeding. If aspirate fluid is the coffee ground color, that means bleeding may or may not be much, because the action of hydrochloric acid on hemoglobin due to peroxidase activity is converted into hemocytin. This is dark brown color in nature. Then we push. If there is a no aspiration of blood from the stomach, it is not indicate there is a upper GI. We can't exclude upper GI bleeding, because as per definition, any bleeding source from oropharynx to ligaments of treats, it is considered as a upper GI bleeding. If aspiration in stomach is negative, then we proceed RISE tube further around 70 centimeter, 70 to 80 centimeter. If bile mixed with blood, it is called hemobilia. Okay. Then we analyze the thing. This is due to hepatobiliary injury. Most likely in case of post ERCP or post endoscopic gastrostomy, percutaneous endoscopic gastrostomy is the leading cause, because nowadays ERCP is the most effective and most common modality in the hand of gastroenterologist to remove the distal CVD stone or placement of the CVD stone in case of stricture of common bile duct or pancreatic duct. So before inserting the CVD stent, first step is sphincterotomy. पहले स्फिंक्टोटोमी करेंगे, उसके बाद स्टेंटिंग करेंगे। 60 to 70% cases, this bleeding stop by conservative management only. Okay. If after inserting rise tube up to second, third and fourth part of the duodenum, only bile is aspirate, that we can exclude upper GI bleeding. इसका मतलब ये हुआ कि अपने सेकेंड और थर्ड पार्ट ऑफ ड्यूडेनम में नेजोगैस्ट्रिक ट्यूब डाला और एस्पिरेशन में प्लेन बाइल है, कोई ब्लड नहीं है, ना गैस्ट्रिक में ब्लड है, ना स्टोमक से ब्लड एस्पिरेट हुआ है। इसका मतलब हुआ दैट मीन्स द सोर्स ऑफ ब्लीडिंग बिलो द लिगामेंट्स ऑफ टीट्स। ओके, दिस इज द बेसिक instrument. Rise tube, nasogastric tube is available in all the emergency room. If you are working in such a setup where all these facilities are not available, we can manage up to some extent, not completely, diagnosed and roughly idea about discriminate and other advantage of nasogastric tube, blood load reduced, and in case of upper GI bleeding, urgent upper GI endoscopy OGD should be done within 24 hours after stabilization of the patient. 24 घंटे के अंदर आपको अपर GI एंडोस्कोपी करना पड़ती है। By the gentle lavage, we clear the blood so that endoscopic view of mucosa is clear in some extent, not in some extent, कुछ उससे क्लियर हो जाएगा। एंडोस्कोपी जब करेंगे तो सोर्स ऑफ ब्लीडिंग कैन बी इजीली आइडेंटिफाइड। सो वंस source of bleeding identified, then the endoscopic treatment of the bleeding source, mostly the duodenal ulcer. The duodenal ulcer, PUD, is the most common cause of upper GI bleeding. Second most common is bleeding esophageal varices. Okay, so endoscopic treatment of the bleeding ulcer is injection epinephrine 1 into 1000 10,000 dilution, and we give injection 0.2 ml in the 4 quadrant of bleeding ulcer. Always remember, only adrenaline or epinephrine injection is not sufficient for the controlling of bleeding ulcer. Along with epinephrine injection plus plasma ergon coagulation, PAC, or photocoagulation, or clip. Importance of the clip is that if ulcer rebleed, we can identify the source of bleeding with the presence of clip. यदि हमने इंजेक्शन के साथ क्लिप लगाया और रीब्लीड किया और हमने एंडोस्कोपी किया तो हमको सोर्स ऑफ ब्लीडिंग आइडेंटिफाई करने में मदद मिलेगी। देन वी फर्दर डिसाइड एज पर द हेमोडायनामिक कंडीशन ऑफ द पेशेंट। एंजियोग्राफी is a very important role for diagnosis and management of the upper GI and lower GI bleeding. In some case, upper GI endoscopy, we can't diagnose any bleeding source. Lower GI endoscopy, colonoscopy, because in colonoscopy we can examine the entire colon from sigmoid colon, ascending colon, transverse colon and descending colon. ठीक है? And up to few centimeter, 15 to 20 centimeter from IC junction. We can't negotiate the small bowel. छोटी आंत को, स्मॉल बॉवेल को, अपर GI endoscopy we can diagnose up to fourth part of the duodenum. It is why very experienced gastroenterologist can negotiate up to fourth part of the duodenum. Okay, but there is a obscure bleeding, means bleeding is present but source is not identified. For that reason, angiography is very important to locate the site of the bleeding. एंजियोग्राफी कैन डिटेक्ट वेरी माइन्यूट ब्लीडिंग, ये बहुत छोटी मात्रा में यदि ब्लीडिंग हो रही है उसको भी डायग्नोज करती है. 0.3 ml पर मिनट ब्लीडिंग कैन बी आइडेंटिफाइड बाय एंजियोग्राफी. वंस वी आइडेंटिफाई द साइट ऑफ द ब्लीडिंग वी कैन thromboembolize the bleeding vessels. So extensive surgery should be avoided, because extensive surgery is the ultimate thing when all the procedure is failed, but it has significant mortality and morbidity. Okay, and another, with the use of nuclear medicine, technetium-19 labeled RBC, we can diagnose very small amount of blood. 0.4 ml per minute blood can be diagnosed by technetium labeled RBC. अगर बहुत ही माइन्यूट ब्लीडिंग है, ऑकल्ट ब्लीडिंग है, अपर GI एंडोस्कोपी, लोअर GI एंडोस्कोपी सब फेल है, देन एंजियोग्राफी एंड technetium labeled RBC scan is very useful for diagnosis the site and source of the bleeding. And other important thing, in case of obscure bleeding, two other modality are also present. First is forced endoscopy, in which pediatric colonoscope we can use for negotiating the small bowel. If this is failed, then another thing is, it is known as capsule endoscopy. Capsule endoscopy, a medium size capsule which has a camera and recording system taken by the patient, and as the movement of the gut occur, it take the picture of the gut during the traveling, during the transition from the small bowel. But complication of the capsule endoscopy is there is a massive chances of retention of the capsule where there is constriction in IC junction. That's all. In next video we are discussing about variceal bleeding management and diagnosis. Thank you very much.